Good to go, sir. All right.
Demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Intraosseous or IO access can serve as a rapid, safe, and reliable route for the administration of drugs and fluids when peripheral venous access cannot be rapidly achieved. The IO route provides access to a non-collapsible venous plexus, which is especially useful during resuscitation. Although providers should attempt to establish IV access as the first attempt for drug administration during cardiac arrest, IO access is an acceptable alternative when IV access is unsuccessful. IO access also provides an alternative route for the administration of crystalloids and colloids. Many sites are appropriate for IO infusion. See your device-specific instructions for a list of approved sites. For adults and older children, the most common sites include the proximal tibia, the humeral head, the medial malleolus, and the sternum. After the IO needle is properly inserted into the bone and appropriately secured, drugs and fluids flow through the bone marrow cavity into the circulation, though depending on location, they may first pass through peripheral circulation. As is routine practice when providing most IV drugs, all IO medications are followed with a flush of 5 to 10 milliliters of normal saline. Keep in mind that even after successful insertion of the catheter into the bone marrow, there is often resistance to infusion, which a provider may mistakenly interpret as incorrect placement. Bolus administration or the use of an infusion pump should help with this. Healthcare providers should keep in mind that certain contraindications exist. Contraindications to IO access include fractures and crush injuries near the access site, conditions with fragile bones, such as osteogenesis imperfecta, and previous attempts to establish access in the same bone. If infection is present in the overlying tissues, IO cannulation should be avoided. After IO cannulation, providers should check the site frequently for signs of swelling and needle displacement. Remember that fluids or drugs delivered via a displaced needle can cause severe complications, such as tissue necrosis or compartment syndrome. IO needles are intended for short-term use, generally less than 24 hours. Replacement with long-term vascular access is usually accomplished in an intensive care setting.
Any questions about IO access? Which y'all already are doing, I hope. We went through it. Are y'all doing IOs in the field? You haven't had a chance? Huh?
I haven't had the opportunity.
Do what? That'll change. All right. Coping with death.
If you have recently experienced the death of a loved one, you may find this video difficult to watch. Please use your discretion in choosing to view the video.
Anybody? will find this difficult to watch.
In this video, we will discuss how to appropriately care for and communicate with the family of a deceased patient, as well as how to care for yourself and coworkers when you experience the death of a patient. Critical care staff can confront death frequently. In our clinical specialties, we see death that is traumatic, sudden, and unexpected in all ages, from youth to the elderly. Unfortunately, emergency and critical care settings are in stark contrast to the needs of the dying and bereaved. They are fast-paced, focused on life-saving, lack privacy, can be very loud, and tend to have a poor physical layout. The dying and bereaved need time, privacy, and to be a priority. As healthcare providers in these areas, you may have to deliver news of the patient's death to the family. Let's watch a scenario of delivering this news poorly. Afterwards, discuss how this situation could have been handled better.
Hey, sis. What's going on with that? Any news, or?
I went to see him on my way home, and we were having coffee, and we were talking, and then he just gets this strange look on his face, like he was confused, and just fell down in the kitchen.
I was worried something like this was going to happen to him. You know, he's so stubborn about taking his blood pressure meds, and
I rode with him in the ambulance, but I hadn't seen him since they took him into the ER about 30 minutes ago.
has anybody giving him an update, or?
No, I keep going to that desk over there, and all they tell me is that I have to wait for the doctor if I want any more information.
Are you Mr. Hammond's daughter?
Yes, I'm Sarah. This is my brother, Jimmy.
Dr. Kurtz.
Can you please tell us what's going on with our dad? She's been asking for half an hour.
I'm sorry, we've been very busy, as you can see, but I'm afraid I have some bad news. I'm probably going to make it.
Didn't make it. I thought we got here in time for you to help him.
He had what we call a cardiac arrest, and his heart stopped.
That's not possible. He's 68 years old. This doesn't make any sense.
I'm sorry. We tried everything we could to get his heart started again, but we just couldn't. Sometimes these things happen.
He was fine earlier today.
I understand how you feel. I'm going to get a social worker in here, one of ours, to explain some of the details. I have to get back to some of the patients that are waiting on me in the back. Stay strong.
Wait a second. I want to see my dad.
You think that was handled appropriately? You?
Some family members may become violent upon hearing the news. It's important to keep the family members and your staff safe.
You know those big two wooden doors when you're going into Southeastern? Had a 15-year-old that was on a four-wheeler without a helmet get killed. And his daddy busted those two wooden doors with his foot. They had to be replaced. So people will get violent and people will get upset. Okay? You have to expect that.
Safe in such a situation, so don't go alone. Provide information in small amounts. They will only be able to handle bits and pieces at a time. Be sure to use appropriate language to convey your support. Even though we may have the best intentions at heart, our message can come across as insensitive. For example, instead of saying, "I understand how you feel," say, "I wish it had turned out differently." Rather than saying, "It was their time," say, "This must be very hard. What can I do for you?" If you are the person designated to assist the family, use common language and not medical terminology when explaining efforts to the family. If ever you are responsible for delivering bad news to a family, remember to be clear and accurate and do it in private. You are about to play a role in one of the worst memories of a person's life. Deliver your message the right way, and you have the ability to prevent additional anger and pain from being added to an already tragic situation. It can be helpful to have more than one person deliver the news, for example, a doctor and a nurse. Ideally, family members should have the option of seeing the body. Again, this is an option, and they shouldn't feel pressured or obligated to do so. Many facilities are utilizing things such as a comfort cart to help personalize the sterile environment of the patient rooms. You should speak with your healthcare system and discuss ways that are appropriate to better help families in this traumatic time. Now let's watch 2 scenarios of better ways to explain the death of a loved one.
Beth, I got respect for you too. What's going on?
I couldn't watch anymore. But the social workers didn't keep me up.
What happened? What did he do to him?
I don't know, he was outside to me and he really did good for me. So I called for help and he came fine in the ambulance and then when they were bringing him in, he was not responding and couldn't breathe again. I don't know what's going on.
Dr. Evans, these are Vicky's parents, Mr. and Mrs. Smith.
Hi. I'm Mary Evans. I'm the doctor who's been caring for Vicky.
And I'm Martha. I've been keeping the left updated.
How is he, doctor?
I'd like to give you all an update in private, so maybe we can...
Sure, let's go down here and we can talk.
So I understand he didn't want to be in the room when Vicky was in trouble. And I know that Martha has been giving me frequent updates. But I have some bad news. After you left, Vicky stopped breathing. And shortly after that, his heart stopped. You worked very hard on him. And we did everything we could. But we weren't able to restore his heart. I'm sorry to have to tell you this,
I don't understand.
That's a sound you never want to hear.
Did he ask for me?
He never did like that. But I know he wasn't really in pain, and if he didn't suffer.
Can we see him?
Of course. I'll go talk to the nurses and make those arrangements. In the meantime, Martha is going to be here for you, and she'll be able to help answer any questions that you have. I'll talk to you again if you've had a chance to see it. I'm so sorry.
I know you must really be shocked and hurting right now. And I'm here to listen and to answering questions that you may have. Is there anybody I can call for you? Is there anything I can do for you while we wait?
I don't know.
I can't really think right now.
Yeah. Do you want some privacy, or would you like me to stay?
Can you please stay?
Of course, of course. I'll stay with you as long as you'd like me to.
Think.
More and more, it's becoming common practice for the family to be at the bedside to witness a resuscitation. Studies have shown that allowing families to be present can actually help the grieving process. Please stress that family presence during resuscitation is an option. They should not feel pressured or obligated to stay. They should also be able to come and go during the resuscitation as they choose. Have a designated staff member with medical knowledge remain with the family at all times while witnessing efforts. It can be extremely helpful in the grieving process if they have their questions answered about what they have seen.
This is an excellent team. They've been working hard for about an hour, so she should be out soon to talk with you.
I'm Dr. Mary Evans. I've been caring for Ricky. I know that Martha has been keeping you updated, but unfortunately I don't have any good news. We will say that we're still doing CPR, but in spite of everything we've done, we haven't been able to restore Ricky's heart. We are going to stop CPR, but I wanted to let you know first.
Wait, what? No.
No, Stephanie, you can't.
I'm sorry, I know this is very difficult.
I understand.
Hold compressions. Stop CPR. I'm so sorry.
Can I do him?
Of course, I'll take you.
While our focus is always on our patients, and in this case, the family of the deceased, what about us? What about the healthcare professional? We all experience both personal and professional trauma. Every person has a different threshold and range of events that can be conceptualized as traumatic. The negative outcomes from this trauma can be long-lasting. Effects can be physical, psychological, emotional, social, and spiritual. Possible examples are depression and anxiety, avoidance of resuscitation situations, hypervigilance in resuscitation situations, drug and alcohol abuse, the routinization of death, lack of compassion, and changes in worldview. We truly are the wounded healers. So how can we take care of ourselves? In the work setting, the two main avenues are informal and formal debriefs. An informal debrief will take place within a few hours of the actual event. There is usually more involvement in this debrief because it's fresh and everyone involved is present. A formal debrief is usually 48 to 72 hours post-event. It is most helpful to involve all providers who took part in the patient's care, including pre-hospital, ED, and ICU staff. We must develop a strong, positive support system at home and work. Intentionally take time away to decompress and find a way to engage in physical activity. Exercise is extremely helpful in relieving stress and providing an outlet. Finally, be aware of your stress responses and don't be afraid to reach out for help when you need to.
Questions? Comments? All right. Wait right here. Okay. Listen to me. I'm gonna send this piece of paper around.